So, we've got all the titles up here, MUS, somatisation, etc. I'm not going to go into that discussion and debate at all at the moment. But what I want to just present to you is a brief overview of MUS, very brief, some of the main characteristics, patients' explanatory beliefs and expectations. So in a sense, it's doing a kind of composite of everything we've heard this afternoon. And Frank and I have developed a model which is a body-oriented, holistic model. So I will present some of our results about that and then some of our key findings. And you will be getting the slides, so please, you don't have to take notes or anything. Okay, so what it's about, and we've heard a lot about this already today. Medically unexplained symptoms refer to persistent bodily complaints for which adequate examination and investigation, and this is what patients are often wanting, do not reveal sufficiently explanatory, structural, or other specified pathology. So I mean, I don't need to teach my grandmother to suck eggs, you know all of this. And these symptoms are often chronic in nature, tiredness, persistent pain, gastric symptoms, and they often cause people distress and they have an important psychological component. Although we know that this group of patients, in my experience certainly, are not really keen on taking into account the psychological component. It's very costly. It's firstly very costly to the patient. And I suppose I'm taking a slightly different perspective, sort of filling out what Peter was talking about earlier. So there's a lot of functional impairment. These patients are really struggling in their lives, health concerns, and significant health concerns and distress. And when compared with other chronically ill patients, they report a much lower quality of life, comparable or greater impairment of physical function, and poor perceived general health and much worse mental health. So these patients are really struggling in their lives. They're not coming to us because they just want to have something to do. It's really difficult for them in their phenomenological everyday experience. It's also costly for all of us. For you as GPs, I'm a psychotherapist. I think the latest research shows that it's about 30 to 50% of appointments in primary care. This is a huge amount of time spent on this group of patients. And of course, I think we've already had the idea about heart sink patients. It's tied to a range of negative emotions for GPs, and not just GPs, all of us as professionals. Feelings of inadequacy, resentment, fear of patients who may manipulate the course of treatment. And again, we've heard all of these things already today. Further, it's very costly to society in general and in terms of financial costs. So we estimate that in terms of direct costs to the NHS, it's $3 billion a year. I think that's about the gross domestic thing of the whole of the Republic of Cyprus, 3 billion. And it's about 18 billion in terms of costs associated, so family members, benefits, loss of work, etc. So it's a huge cost to us. And and this is actually rather depressing from the King's Fund report, most of this expenditure currently delivers limited value to patients, and in fact it could even be harmful. And when I read that, I was really distressed actually, because we're all trying to do our best for this group of patients, and to think that actually we may be harming them unwittingly is really depressing. So, moving on, the main characteristics. So firstly, it's usually a pattern of symptoms emerging before the age of 30. They are recurring in nature, so they don't just disappear. We can't cure these patients. And there's a lot of overlap with what we've heard today already. Predominantly multiple sites or generalized pain, and I've really had patients from up here right down to their toes and everything in between. Symptoms are neither intentionally produced nor fully explained. So I think this is actually really important. This is not a conscious decision on the patient to come and tell you this is wrong with me. This is really happening to them. And of course this leads to medical attention and seeking behavior. And we also had some kind of sense of histrionic behavior that Peter introduced also. And I think most difficult is that there's an impairment of social, interpersonal and occupational functioning. And the GP, the people who spoke about, your person in the practice, how awful it is for that patient and for the whole family. their lives have come to an end, really. So, how do we get to this, and how do we begin to try and understand a little bit of these patients' beliefs about their symptoms? And I think we've made quite a good differentiation here between the importance of organic symptoms and having something organic versus something functional, which is much more difficult to deal with. So if it's organic, it's in the body, it's much easier. If I have arteriosclerosis and I've got a blocked artery, it's great because you're going to fix that for me. You're going to put a stent in and I'm great. If I've got non-cardiac pain, and I've got a woman at the moment, she's at last, after about a year, starting to understand that this is related to stress, it's in the head. Well, if it's in the head, that's not a very good thing. If it's organic, it's real. If it's functional, it's unreal. This is the patient's belief. If it's organic, I'm not to blame. If it's functional, I am to blame. There must be something wrong with me that I keep doing this because they can't find anything in my body. If it's organic, I'm not weak or flawed. It must be genetic. It runs in the family, etc., etc. If it's functional, there must be something up here. I'm weak and I'm flawed. If it's organic, it can be cured. Obviously, there are a lot of conditions that can't be cured, but there is that hope, that possibility. If it's functional, it can't be cured. And then I think probably the most important thing is that if it's organic, there's no stigma, whereas if it's functional, there's often a stigma about it. So, what's wrong with you? We saw that very clearly in the patient videos. They were stigmatized by the family and work and so on. Nobody could actually make sense of that. And if you can't make sense of it in a sort of reductive rationalist way, then you start being viewed in a peculiar way. So you feel that there's a stigma. Just some research findings, the Cochrane Review. I know you've all been talking about loads of medication, but these are some non-pharmacological interventions for MUS, which is medically unexplained physical symptoms. 21 studies, 2,500 people, and it was found that all psychological therapies, so this included the whole range from CBT right down to physical therapies, were superior to usual care in terms of the reduction of symptom severity. So it seems as if we introduce some kind of therapeutic dimension, and that doesn't necessarily mean CBT or psychodynamic psychotherapy or family therapy, but some kind of therapeutic dimension, there seems to be a reduction in symptom severity. However, the effect sizes were small, but at least there was some effect size. Okay, so what works well? And I think there's quite a lot of research to show now that enhanced primary care with specialist input works well. My own experience was that there was a time when Frank and I ran a somatoform disorder clinic in secondary care, which I discussed with Peter at some point some years ago. And patients actually were referred to that. Quite a lot were referred from primary care in Newham, mental health at that point. The problem is that this group of patients didn't like to come to secondary care. For all the reasons that we've spoken about, they don't like to think that there's a psychological component to it. However, the patients that did come and we introduced a sort of body holistic approach, they did really well, and their symptoms and so on were really improved. Hence, from there, we decided to actually take the work into primary care. Again, I don't want to be teaching my grandmothers to suck eggs, but it's important to have a diagnostic openness. So not to close down and say, actually, I can't find anything wrong with you. And that connects, of course, with the therapeutic relationship, therapeutic listening, flexibility and sensitivity. And certainly when I was going around the room listening into some of the discussions, of course, you're thinking in that direction already. But there's a dilemma. You have 10 minutes. How much do you do in 10 minutes? And how can you do all of this in your 10-minute slot? And I suppose my belief and trust and faith in GPs is that, my dad was a GP, by the way, and I have very good friends who are GPs, is that if you become mindful of this kind of approach, it does start changing how you do things. So just a mindfulness of the importance of this is helpful. It has been found that there's a range of treatments with evidence which do work. Reattribution therapy, and I'll give you a little example of that later. Progressive muscle relaxation and related body-oriented techniques. And CBT, though I think CBT is really best for gastric things. I think that's where the main evidence lies. and physical therapies. Angie was talking about physical therapies, graded exercise, and embodied approaches, so where you try and include the whole person. So, best practice in MUS care, and I feel a bit embarrassed about telling you what you should be doing, but anyway, these are just some ideas that you may want to think about. Again, it's a bit like going back to basics, and you know, when a musician starts the day, they go through their scales. When a dancer starts, they go back to the bar. So I always think it's really good to go back to basics, just to review, to bring that back into the forefront. Just before I get into the do's, I want to just think a little bit about how we conceptualize MUS, or however you want to name it, as a mismatch syndrome. What do I mean by this? There's a mismatch between the patient's position and the professional's position. So firstly, in terms of the explanatory model and the belief of the patients, for the patient it's all in the body. For the professional, we often think it's all in the mind. And this is a little bit stereotyped, but I think it does give us a flavor. The language that we use, the patient, it's an unmet need. Please, doctor, give me another thing that I can try. Maybe you can change my medication a little bit. Maybe another MRI or a CT scan, whatever. Whereas what are we talking about? Health anxiety. The emphasis in therapist, I'm in pain. And what are we doing? We're doing this objectifying. We're talking about the pain. The pain. And this is the incurious thing about the body. It's both subjective and objective. So we can easily get into the objective part rather than the subjective state. This is an interesting one, desired location. I think these patients always want to be in services, whereas I think, I don't know if I speak for everybody, but I think sometimes we'd like them to be out of services, especially when there's this file that, well, it's now on the computer, but that goes on and on and on and on and on. And then, of course, the effects, often with patients, there's poor effects, poor outcomes, and for us, it's very high costs. So, bearing that in mind, let's think a little bit about the do's. So, the first thing, it's really important, and again, I picked that up as I was going around the groups, understanding the patient and the effect that these symptoms may have on them. Show patients that you believe they have the symptoms. This is really important. You know, even when the test results come back and say there's nothing, these patients are experiencing it. Be honest when a patient has unusual symptoms. You know, there are a lot of things that we as therapists or GPs or professionals or clinicians, in whatever way we are working, we actually don't know everything. And was it Peter who mentioned about Google? So, you know, we can all refer to Google at times. This also came around in the discussions we were having. Think about how we can empower the patients. And this came out so clearly with Jade and Marla. Please let me be part of the discussion. See me as a whole person. Don't just see me as somebody with symptoms. Explain the links between physical and psychological stresses if you feel a patient is ready for that. And negotiate a culturally responsive explanation. And I think this is quite important in Newham, where we were working with a lot of a BME population. We had a group of Bangladeshi women who had no conception about psychiatric services, so there was no point in trying to explain things psychologically in that way. We had to find a way to allow them to understand it from a different perspective. So always we have to be culturally responsive in our explanations. And finally, Peter spoke about this also, all symptoms are not just about a physical thing, but we need to widen the perspective. Biopsychosocial, the human being in front of you, not just the illness. This is a sort of reattribution example that we found in the British Journal of General Practice. It's a little time ago. How we can, and it's an example of how we could explain MUS to a patient. So, I will read it. The stress you have been under recently, so you're just introducing the stress, has led to contractions in the muscles. So, you know, when we do this exercise, you can feel the stress. And these muscles, you have the same kind of muscles around the gut, which is like a tube. This leads to pain and discomfort experienced in your abdomen. Let's talk about ways in which we can help you to manage and control the pain. So immediately we're coming out of that position of saying we're going to cure you, but we want to work together to see if we can find a way to manage and control the pain. Okay, don'ts. Tell them that you find nothing wrong. There is something wrong with them. Tell them the symptoms are normal. They're certainly not normal for these patients. Reassure repeatedly, and that's come up a little bit in our discussions today. That just becomes a never-ending cycle, constant reassurance. Though I was doing a training for a group of GPs a year or so ago, and one doctor had found a solution to the constant consultations this patient was making, and they were medically unexplained symptoms. And he realized that he was offering reassurance, and he did realize he was also creating some dependency. But rather than coming to see him every 2 or 3 weeks, he'd say, I will see you again in 2.5 months. And so he had these set times during the year, and that was enough containment for the patient. So I thought that was a very interesting way of using reassurance, but not in a completely over-dependent way. Tell them there is nothing you can help them with. Give results of normal tests and reassure and think that this will help. It's already come out very clearly that constant reassurance isn't going to help anybody. There's something more going on. Okay, so that's the sort of background. I want to talk a little bit about an integrated MUS primary care person-centered one-stop shop that we've been working on for some year. That's Frank, me, and at that stage we had a researcher, Ivan Zamet, with us. We worked in a group of 7 GP practices in Newham. It's been written up and it has open access to the British Journal of GPs if you'd like to look at it, or you can email me. Okay, so our objectives, very, very lofty objectives, very, very ambitious. Deliver an integrated care package incorporating best practice from primary and secondary care. Increase MUS satisfaction through adequate treatment, signposting and care. So this is an enhanced PC. We weren't expecting the GPs to do all of this. Improve engagement techniques between clinical professionals and MUS patients. Make the patient feel understood and enhance their coping strategies. Hopefully we wanted to reduce the intensity, frequency of somatic complaints and improve their functioning, and reduce unplanned attendance in healthcare in general. So this was a holistic approach, patient-centered and body-centered, and we had 4 sections to it. So first there was identification through a specific somatic symptom algorithm. Then there was an engagement strategy through our researcher where we really tried to create time for the clinician to think how, when, where, and under what circumstances these pains took place. There was an in-depth series of somatic symptom questionnaires, the SOMS and the PHQ-15 and the EQUAL, and a post-therapy assessment, quality of life. And then we offered some innovative approaches. So we gave patients a psychoeducation pack, and then we offered them 8 sessions of mindfulness-based stress reduction. Some of you must be aware of mindfulness. It's sort of the flavor of the day. And then we offered a body-oriented psychological intervention that we called the Strategies for Better Living group. So neither of these were considered psychotherapy groups, though they were actually run by psychotherapists. So we were offering them something a bit alternative, engaging with the body, which is where the problems are starting from, or where they're experiencing the problems. These are the leaflets. You'll be getting the slides. These are the leaflets we gave out to patients, and you'll get the slides so you can look at them. And there's a clinical algorithm. Again, I'm not going to go through this. You probably know some of this algorithm anyway. And then just some quotes. After these patients had had quite a short intervention, I am now helping myself rather than depending completely on my family. When I was there, I found I was not the only one going through those problems, which I think are unexplained. And this is the kind of helpful effect of being in a group and being with other people who are sharing similar problems. You know the old adage, a problem shared is a problem halved. Something about being with a peer group who are having the same problems was really helpful. It made me realize I was in denial about the wider picture of my life. So we took the attention away from the symptom to a much more holistic understanding of the whole person. And then I learned to be kind to myself. It was you who said you were learning to be kind to myself. It has really turned my life around and empowered me. So, outcomes, and I'm going to end just before past, I promise. I spoke about the three costs. So firstly, the cost to the patient. We found that there was an improvement in quality of life and somatic symptom levels. We found that, interestingly, the impact on GPs was it gave the GPs hope. And we've got a little clip on our website where one of our GP champions from Newham talks about how, having been through this program, her patients, it changed how this patient viewed herself. And the result was that she didn't keep phoning the surgery, which had an impact on the administrator and the secretaries who didn't feel that heart sink feeling. And when she went to see the GP felt that there was some hope in her, and so the GP had some hope. So they got out of that kind of downward cycle of actually there's nothing to do and we've reached a cul-de-sac. But I encourage you to listen to Dr. Hussein's 6-minute talk about how this project impacted on her. And then, of course, there was reduced service utilization, actually by about 30%. So that was quite significant in the 6-month follow-up period. Right, and then these are just sort of some discussion points. Managing MUS in PC, in primary care, we know it's never going to be easy, it never will be easy, it never was easy, but we do know that embedded in primary care, that's how it works best. We found that it's possible to engage BME populations. Everybody engages. A high level of sensitivity is required, cultural, social, personal. At a certain point we found it was better to have an all-women's group because of religious sensitivities. The embodied approach was accepted by 2/3 of the patients. Once engaged in this, actually, even if they didn't attend all the sessions, there was an improvement. Thank you. And if you'd like to look at our website, please do.